everybody, and welcome. My name is Eileen West, and I am a general internist in Fairfax, Virginia. And hi, everybody, and welcome. I'm Dr. Eileen West. I'm a general internist in Fairfax, Virginia, and I am here to talk about some of the newest COVID-19 updates. We've been doing this series of updates every couple of weeks, so I hope that you enjoy it and learn some information, new information over the next 30 minutes or so. So I'd like to start by going ahead with some statistics related to COVID-19. These last couple of weeks have seen some new findings and changes. So as you know, we are in a full-on increase in COVID cases around the globe. The global statistics show that there's 34 million people of total cases of COVID-19 now worldwide. There are averaging over 200,000 new cases per day across the globe. We have crossed a major milestone, which is more than 1 million deaths around the world from this disease. However, we've also seen 23 million plus recovered patients who have gone on to do fairly well after COVID infection. The United States is leading the charge with the number of overall cases at 7,233,000 cases or so. India is rapidly catching up at 6,225,000 cases. Brazil is third with about 4.8 million cases, and Russia is now fourth at about 1.2 million cases. So lots of infection. It continues to spread. Areas that were previously quiet have now started to pop up again with various hotspots around the globe. Travel is still significantly curtailed between countries, but starting to see some re-entry in international flights. In the United States, of our over 7 million total cases, we've had 207,000 deaths. We're averaging around 42,000 new cases a day, and unfortunately that number is going up. Coronavirus cases are rising in 25 states around the country. New Mexico specifically had a 50% spike in new cases over the last week. Pretty much the whole northern half of the country is experiencing increasing numbers of cases, with the exception of Maine, Vermont, and New Hampshire. The southern U.S., the good news is that in the southern U.S. now, a number of states are doing better with a decrease in the number of new cases. So particularly Arizona, Florida, Texas, and Virginia are all having a lower number of COVID cases. We're now doing about 204 million. We've done 104 million cases nationally, and just in this last week alone, the testing has been up about 9%. So. In Virginia, we're close to 150,000 cases now in the state. We're running at about between 900 and 1,000 new cases per day. We've seen a shift in the focus over the last few weeks from the coastal portions of Virginia into some of the college towns and some of the inner cities and into some of the more rural areas. We've seen 3,185 deaths from COVID so far in Virginia. In Fairfax County, we have 21,000 confirmed cases, running at about 90 to 100 new cases per day in Fairfax County, with 588 deaths. And through the Inova Health System in Northern Virginia, they've overall tested 117,835 patients, with 13,000 positive cases since this whole process began. But the current hospitalization rate right now is not significantly higher than it has been for the past few weeks. They believe they have 66 currently hospitalized patients with COVID-19. So gives you a bit of an overview of some of the things that we're dealing with. So I want to draw attention to a couple of scenarios that I found interesting in the news. The first is I'd like to talk a little bit about New York City and what's going on there, because we have seen a bump in cases there. At one point, the positive percentage of COVID tests in New York City was running close to 20%. And then it dropped all the way down toward the end of this summer to well below a 1% positive rate, which was very exciting and was lower than what we'd seen before March. But now, just in the last week, the percentage of positive cases is going up. We've now risen to 3% positive cases in New York City, and that's the highest rate that we've seen since June. The same day that this report came out, and by the way, I'm always interested in what's going on in New York because I always wonder if Washington, D.C. is going to follow suit. So Tuesday was the day that the report came out, 2 days ago, which unfortunately coincides with the same day as elementary schools starting back up in-person classes, and also the same day that New York City is opening to indoor restaurant dining. So we're watching to see how all of this evolves. They have been on the evaluation of the different neighborhoods for New York City. They've identified that 6 neighborhoods are responsible for about 20% of the new cases. And interestingly, at this time, all 6 of those include relatively large Orthodox Jewish populations. So the city has jumped right in to do calling to people in these neighborhoods, and they're doing it in multiple languages. And they're also driving trucks through the neighborhoods to let people know about issues with COVID increase. And they're also deploying localized trucks, mobile testing centers to these areas, and distributing free masks, gloves, and hand sanitizers in an attempt to curb this increase that they're seeing. So to date, I'm not aware of any of these issues really getting launched in the Washington, D.C. area, but our case count has been pretty stable for a while, but we are, of course, always watching to see what happens. I'd like to go ahead and talk a little bit today, switch gears and talk a little bit about some new developments with rapid testing. There was a really interesting article put out by Brown School of Public Health on a new testing approach for rapid testing. There is really in development now a new generation of fast, inexpensive testing that is coming into more mainstream environment or availability. The rapid testing is appealing because receiving fast results means that a patient knows sooner about whether they need to isolate to avoid transmitting the virus to others. So the goal is to identify asymptomatic people before symptoms develop, and we want to do everything we can to kind of return the world to a more normal environment where schools can safely be open, workplaces can safely be open, and we can get back to our daily lives. In the U.S., we're testing just shy of 1 million tests daily right now, 935,000 at the last case on average per day across the country. But at a bare minimum, studies show that we really need more than 4 million tests per day to really accurately and safely reopen. And we really need more like 14 million tests per day to control the spread of coronavirus. We might get to that goal by the end of 2020. It's going to involve, a significant uptick in the availability of tests. But this is the moment, I think, now where these rapid tests are going to start to evolve and start to pick up in number, and we're all going to get more comfortable with more available testing. We really need to continue to develop a quick strategy to get these tests out to the public. So the new tests, and there's another really interesting article that was in Healthline Health News called "Here's What's Going On with Rapid COVID Testing," and I thought that I would just highlight some of the features of that article to give you some idea for where we are with new tests. There are three kinds of tests. There's the rapid antigen test, which tests for particles, proteins that are a part of the virus itself. And if those particles are identified, then they are specific to COVID-19 and can give an indication about how much of the virus a patient has in their system. The second type of test is what we know as to be the gold standard at this time, and it's a PCR, or polymerase chain reaction test. And the rapid PCRs are slowly evolving, but the regular PCR testing, just so people understand it, is necessary because there's this process that takes place. You know, the molecule is an RNA molecule, and the RNA has to be converted to DNA in order for accurate diagnosis, and through this polymerase chain testing, PCR testing. And that testing process is where we lose time in the testing, and also that drives up the cost of the test. But to date, it's still the gold standard. So everybody's working on a fast way to do these PCR tests, and fortunately we're making some headway. So the advantage with the speed of the antigen testing is, as we talked about, that you can get these test results quickly, you can act on them quickly, you can make decisions about isolating and identifying contacts with the information if a test is positive or negative. The test is great. These antigen tests are really good because they really do still identify the most infectious individuals. There may be some false negatives, but the most infectious people are still going to be testing positive most of the time for these rapid tests. But where the real benefit comes is when we get to the point where we can do these rapid tests over and over, every 3, 4, 7 days for people, so that you can know at that time that it's safe to intermingle and to go about your business. So the antigen tests that we have available now, there are a slew of them that have results available in anywhere between 15 minutes and a couple of hours. Some of the most commonly used ones now are the Sofia Quidel 2, the BD Veritor test, and one called the Binex Now by Abbott. And these tests are becoming more readily available. We are able to purchase them in clinics, and a number of units have been distributed to nursing homes and other major facilities around the country. So these tests they're here and they're available. And I know that a number of people in my building are now offering these rapid tests, including our practice. What's coming in development now is these rapid PCR tests, which are more accurate. And so the polymerase chain reaction tests are getting to be more available now. The Abbott ID Now was the first one that came out. They had some quality control issues at the beginning, which my understanding is they've been working on that to improve those issues. There's a Cobas test by Roche, a Q COVID-19 test by Q Health, an Expert Express by Cepheid, and the Acula test by Nisa Health. And so these will gradually make their way into the marketplace and become available to you and me as we do these, as the testing progresses. There's also a new one that's got the attention of a number of people called COVID Nudge. It's a 90-minute test, and it's the PCR test. The sensitivity and specificity data look really, really good. There are almost no false positives, and that was 94% sensitive, meaning that there was a 6% or so chance that a negative might in fact not be a true negative test, but still very good numbers overall. There are also a lot of developments on the saliva testing front. There is a company called Ambry that is doing a saliva test kit, which we are about to begin offering to patients. The advantage to this is that it's an at-home test, so you can purchase the test and take it with you if you're traveling or you're going to want to test in a week or 2 weeks. You can have this test kit available and send it in. Federal Express it overnight to the lab. The lab runs the test in about 48 hours, and that is a PCR test as well. There is also a test called Saliva Direct that's being produced by Yale that is a similar process. And then there's the University of Illinois is doing a rapid PCR test. It's a saliva-based test. This one is faster and can give you the results in a short period of time. Right now they're being offered to University of Illinois faculty and students, I believe, but it's not widely available to the public yet. There's another one called iCore Tech, which I'm particularly interested in because for the first time it sounds like we may be able to get a system where it will check for active SARS-CoV-2 infection and also detect antibodies. And both of those tests can be processed in under 5 minutes. So iCore Tech, let's see how that one evolves. The at-home testing, I think, will continue to develop. I know that LabCorp now, you can go online and answer a series of questions through their questionnaire, and if you qualify, they'll send you a test kit. The test results take 3 or 4 days to come back, and there's an out-of-pocket expense of, I don't remember, $129 perhaps, $159 through LabCorp, and Quest has just begun to offer the same thing. So lots of testing options coming into the forefront. So basically, keep your eye on the tests. There will be more and more tests as time evolves. The more testing we do, the more quickly we're able to identify positive cases, the better we will be at controlling the spread of the disease. So, all right, be interested to hear if anybody has questions. I'm going to go ahead and look at the chat now and see what I can find there. All right, who is a good candidate for a rapid COVID test? That's a great question. And there are some people where the rapid test won't be effective. You have to look for the distinction between a rapid antigen test and a rapid PCR test. The rapid antigen test is going to be really appropriate for people who it will work for if anybody's having symptoms, if anybody's had a direct contact for exposure, or if anybody really just wants to get checked before going to work or traveling to a different office location. The thing to know is that there are, for international travelers still by and large are required to produce documentation of a negative PCR test that was taken within 72 hours of travel. And there are some states in the United States that are also requiring a negative PCR test before entry. And I believe Massachusetts and New Jersey are on that list. In some settings, just a rapid antigen test is sufficient for travel or for returning to schools, for college, or for regular classrooms. So many people will qualify for that rapid antigen test, particularly people who are thinking about getting tested on a regular basis, just to screen and make sure that they're fine. So those tests are a great tool in our toolkit. You just can't have a rapid antigen test if you are planning to travel internationally. And what some places are doing is, if a person is highly suspicious for COVID and the rapid test is negative, many places, and we've started to do this in our practice as well, if they've had direct household contact exposure or clear symptoms that are suggestive of COVID-19, then we go ahead and if the rapid test is negative, we make certain that things are okay by going ahead and sending off the PCR as well. All right. What are we in the second wave? And is it still supposed to be more severe? Those are great questions too. We are not yet in the second wave, as far as I can tell. None of our numbers have approached those of the massive significance that people were experiencing early in this process in April and May on the East Coast. But what we're seeing is that some of the many locations around the country that didn't have a first wave are now having their first wave. So it sounds like a second wave, but it's, I think, really the first wave for these places that haven't gone through it yet. A second wave is what we might be seeing or beginning to see in New York City. So a second wave could potentially be quite significant and could be worse than the first. It remains to be seen. We have reached the 3-week mark past Labor Day weekend and past the opening of many schools, and although cases are increasing, they're not increasing at a horrifying rate. So let's see, stay tuned to see how all of that evolves. What do you think is a realistic timeline on a vaccine? People are very interested in the vaccine because we really believe that a vaccine is going to play an integral role in helping us get to the end of this whole pandemic. There are 4 major vaccine candidates that are in late phase trials. Then there are many more that are in early phase trials. And the late phase trials may be ready to go fairly soon. But they are not ready now. We are, I know there are forces at play that are really eagerly anticipating a very quick vaccine. I think we need to modify our expectations a little bit. I would be very surprised if a vaccine is actually ready for distribution before the end of 2020. Remember, we have to complete the final phase trials, and then we need to ramp up distribution. At this time, there is no clearly established plan for distribution nationally. I know on a global front, a number of countries are banding together to make a pact to try to get the vaccines distributed in the most highly needed areas around the globe as quickly as possible. The United States and China and one other country, I'm forgetting now, are not participating in that process. But as far as distribution in the United States, there's still a lot of work ahead of us to do before we can be optimistic about a vaccine that's really ready to go. Do I think maybe, comfortably by summer 2021? We all hope so. But it will take probably throughout 2021 to make that vaccine truly available to everybody. So I hope that helps. What questions do all of you have? Are there additional is there additional information that might be helpful for you as you go about your daily life? Are there other things that you would like to know about COVID-19? If so, go ahead and let us know in the chat section, and I'll try to address them. And you can also email me or send me a message through the Facebook website if you have additional questions. I'm always happy to answer them. So. Well, I'm not seeing any new questions, so I want to say thank you to all of you for tuning in. I hope this has been informative and helpful for you, and we hope to see you back again in another couple of weeks. We will have a wellness coach speaking with us next time, so I think that'll be really interesting to hear some of her thoughts and perspectives. So. Let's see. Oh, there's one more question. I'll go ahead and answer that. Does there seem to be a big increase in cases since school started? And the answer is yes, we are seeing an uptick. And, really the extent of that is still being evaluated. Because remember that the time from exposure to development of symptoms can be as long as 14 days. So it's, the jury's still out. I know most of the major schools in this area started after Labor Day, so we're at about 3 weeks now. So we are seeing some cases, but we, it's not hugely blown up except in isolated communities right now. So. All right, well, thank you everybody for tuning in, and we hope to see you next time. This is Dr. Eileen West signing off. Thank you so much. Bye.